Thank you so much. So today we have a very interesting topic that was handed over to me by the Next Gen team to tackling AMR in human health, innovations and behavioral change. It was a very challenging and exciting topic to discuss, and really pumped, and I hope you guys are pumped to hear what I have to say. And I'm sure you already know most of what I'm going to say, but so we will all be going on this journey together. So welcome once again. I will start off with just telling you about myself. She already gave my bio. So I'm an infectious disease physician. I'm based in the US. I've been practicing for about 10 years. I do both clinical medicine and I also inpatient, hospital-based, a little bit of outpatient, but mostly 90% hospital-based practice. And I also faculty with one of the medical schools here. So I do teach medical students. Most recently, I'm passionate about metagenomics, and heard someone introduce himself as genomics. So I'm not a scientist, but I'm just really interested in that science and its power to enhance clinical decision-making and improve patient outcomes. You can reach me on LinkedIn, and I have nothing to disclose. So let's get right into it. And since I'm a clinician, I'm going to start off with a case presentation. I found this case online and I thought it was a very good case to get us all into the mode of why antimicrobial resistance, understanding antimicrobial resistance and its effect is powerful. It's a case of a 19-year-old male. I believe he's in Malaysia. He was a newly recruited army officer and he presented to the hospital with 5 days of fever, arthralgia. Arthralgia just means bone aches or joint aches, myalgia, body aches, headache. If he was in Nigeria, we say maybe he has malaria, right? So productive cough, heaviness in his chest, difficulty breathing when he's at rest, diarrhea, and poor intake. Let's see. So when he presented his vital signs, he had a temperature about 38.5, blood pressure was low, heart rate was high. All of those are signs of what we call sepsis, meaning an infection that is taking over all his body. So when they examined him, he has a crepitation in his lungs, meaning his lungs were not sounding clear. They're expected to sound clear because it's just air in it. So when you have fluid or infection in it, it starts sounding groggy. So he had enlargement of his liver and signs of dehydration and cold peripheries. So his blood work, his white count was pretty normal. Platelets was low. All of these are signs of sepsis. Blood gases were borderline, not good. Chest x-rays showed infection. Bilateral lobar consolidation usually we mean infection. So they diagnosed him what we call a severe community-acquired pneumonia and acute kidney injury. So they started him on treatment. Since he came from home, they started to treat him with what you would expect with a patient who came from home. They gave him fluids, kind of aided his breathing with non-invasive ventilation, and then started giving him antibiotics, simple antibiotics, which you would normally cover what is coming from the community. And then they started him off. When he wasn't improving, they started to give him some antiviral medicine just in case it was the flu, but he continued to get worse. And he eventually needed some kind of dialysis to help his kidneys, but everything persisted. His fever worsened. All of his vitals continued to get worse. His blood pressure got worse. And by the third day, the patient literally actually died in the ICU. So let me pull up my notes. So one of the reasons why I brought this case up, we will talk more about it as we go on, is this guy is just 19 years old. He came in from the community, and you expect to see simple community-acquired bacteria or infection. But he seemed to come in an unusual presentation and died so quickly. So let's go on to the next slide. So what grew out of his culture is lungs fluid that was cultured, and it was resistant to beta-lactams, to fluoroquinolones, and to carbapenems. And if you're familiar with any of these antibiotics, the beta-lactams are penicillin is one of the earlier drugs that should normally treat community-acquired infections. Hello? Did somebody say something?
No, ma, go ahead. I think it was
Okay, are you hearing me clearly?
Yes, we can hear you clearly, ma.
Am I speaking too fast?
No, it's fine.
And the carbapenems are high up there in the chain of antibiotics spectrum. And this bug he grew, we will call it bug over here. The bacteria he grew was resistant to all of the spectrum of antibiotics that were available. It was only susceptible to polymyxin B, which is not something you would typically bring up even for patients that are hospitalized. So he had what we call a big bad bug infection. So I would come back to this case as we go along. So this is going to be our roadmap for today's conversation. We will be defining a few terms so we can all be on the same page, and then we'll address the challenges of antimicrobial resistance, and then we'll talk about the innovations mitigating antimicrobial resistance, and then we talk about the power of behavioral change, and then we talk about practical steps we can take together, and then we can maybe have a minute or some time to take one or two questions. And I would like to have you all engage. I like to have some audience engagement. I don't want to be the only one talking. So let me just throw the question out there and see what responses I get. What do you think happened with this young man with regards to what he grew coming from the community? I already gave you a hint that he was growing something that was completely unexpected. So typical bugs we will see, when I say bugs like bacteria, typical bacteria we see in the community will be simple things like a streptococcus causing pneumonia, but he is coming with what we call Acinetobacter, which is the godfathers of evil bacteria. So what do you think is happening, or what do you think happened to him, and how did he acquire this infection?
From the presentation, I think number one, the young man was treated blindly. So, because from the presentation, he's showing that he's resistant to the penicillin, the beta-lactam, the fluoroquinolones, almost all the common antibiotic. So I feel like he was treated blindly because even the melopenem that he was given in the hospital, he was resistant to it. So he wasn't meant to use it. So I think that was another major cause. They didn't run a sensitivity test on him to confirm the antibiotic to be used. So it also helped the antibacterial to also build resistance to grow further, something like that.
Very good. Thank you so much for that contribution. You're absolutely right. Anybody else? One more person, maybe.
Would you mind repeating the question again, please?
So I was saying this young man, he didn't have any past medical history, meaning he did not have diabetes, or he has not been in a nursing home. He didn't have like chronic wounds where they've been pumping him with, at least they didn't tell us that. So we can assume that he came in young, pretty healthy, and he just came in so sick with this terrible bacteria that you would normally see in people who are in nursing home, who have been sick for a while, or people who have been in the hospital for a long time and have been pumped with antibiotics. So my question is, why do we think he presented that way, straight from home with such a terrible infection? What are our guesses? Well, I'll give you a clue. So I just said that the guy came in with an infection that you would normally find in persons who have been sick for a while. So the question I'm asking now is, how did he acquire this bacteria? It's not something that any typical person who is just going about his day should have in him or should capture an infection like that. So if we're going to make any intelligent guesses, he may have been exposed into a multi-drug resistant organisms become multi-drug because they have had prior exposures back to antibiotics or antimicrobials. So what happens is the more a bacteria or a virus or a fungus is exposed to an antibiotic, the more it builds resistance to that antibiotics. So it's just like if you're fighting a battle, right? And the person, your enemy comes with a weapon, and that weapon, he runs out of ammunition. So you know that, oh, well, I know that he has this kind of gun. So guess what? You come with a stronger ammunition to overpower him. So every time he comes with a different weapon that is not strong enough to kill you, you will be stronger. So that's what happens. So this patient, I'm assuming one or two things, is either he got exposed to this bacteria in the environment, either through the water or through his food. So the bug was already present and he got it on him that way. It didn't develop inside of him. Or when he, at some point throughout his lifespan, he had been getting antibiotics indiscriminately. But let me not get ahead of myself so that way we can go on to our presentation. So the definitions, what is an antimicrobial, right? So antimicrobial is agents that we use to either inhibits the growth of microbes, right? So you can see anti against microbes, microbial, right? So antibiotics is what we normally say, but antibiotics is a type of antimicrobial, right? It's specifically usually for what we use to treat bacterial infections. So antibiotics is a type of antimicrobial. We have antibiotics, we have antifungal, we have antiviral. So I just put a few points here that it could either be static or cidal. So static means some antimicrobials can stop the growth of a microbe from multiplying. It can prevent it from multiplying, but will not necessarily kill it. So basically just can halt its progression, while others are called cidal. So we can call them bacteriostatic or bactericidal. Cidal means, if you think about suicide, all right, or homicide. So cidal means it kills it. So it completely kills it. So you can imagine there are some antimicrobials that are static and there are some that are cidal. And that's based on basically the endpoint of its action. And if we want to classify also based on the activity spectrum, some of them are narrow spectrum. So what it means is they would, if you remember watching let me see, what's her name? Chidinma was saying earlier that they had given him certain antibiotics, but it wasn't broad enough to kill what he was growing. And we will get to that as well. So some antibiotics are narrower spectrum, meaning examples would be like the penicillins. The very early penicillins are narrower, so they kill only a few certain bugs, but then the more later derivatives of penicillin like meropenem or carbapenems, they are much more broad spectrum, so they kill both gram-negative. So that's based on the activity spectrum or the nature or the mode of activity. So then you have the fluoroquinolones, you have the tetracyclines, you have the penicillins, and where they act, the binding proteins, what part of the bug that they attack or how to get access to kill the bug. Also, you can also classify antimicrobials based on the target microbe. So what I mean by that is if, for instance, the antiviral or antibacterial or antifungal, right? So the question now is, what is antimicrobial resistance? So what is AMR? AMR is an acronym for antimicrobial resistance. And simply put, it's when antimicrobial resistance is when the antimicrobial or the antibiotic or the agent that is supposed to kill a specific bug has now become unable to kill it. That's really the simple way of defining it. So when there becomes an inability or ineffectiveness of that bug, we will say the bug has developed resistance, an antimicrobial resistance. So it's not able to resist the effect of that antimicrobial on it. It doesn't matter if it's static, if it was meant to halt its progression, it can't even halt its progression. So if you put an antibiotic or an antimicrobial in the midst of a microbe, right, or a pathogen that is ineffective, it's just like water. It would eat it for breakfast and just keep growing, right? But if it's something that is effective, where it's susceptible, it would die or it would halt its growth. So those are the definitions. So, oops, what did I do? So I just said antimicrobial happens when microbes like bacteria, viruses, fungi, and parasites stop responding to the medicines designed to kill them or to halt their growth. So this makes the antibiotics and other treatment less effective or even useless. Like I said, it's just like pouring water there. They just dance, have a swim, and just keep doing what they're doing, and it doesn't have any effect. So as a result, infections become harder to treat. Just like the case we discussed at the beginning of this conversation, the 19-year-old who came in, the expectation was he was coming in with streptococcus. So I understand what Chidinma said, that, oh, well, the drug they gave him, they should have given him something stronger or bigger. But unfortunately, how it works is when a person comes in, the doctors who are seeing the patient, we do what we call, based on surveillance, based on data that we already know in the environment, right? Or in that location, what I mean by environment, that location, you have an intelligent understanding of what antibiotics to present to that patient, right? Because every patient who comes into the hospital, we can't just go and bring our bazooka, right? I like to describe my antibiotics like weapons. So please excuse me. We can't just go and bring our bombs So if we use the bombs, guess what? We would actually be enhancing antimicrobial resistance. So we always typically will start with we always want to be at target. So we want to bring the best gun that will give us precise hit at the specific bug we're trying to target. So that is always the goal. So the narrowest spectrum for what you're trying to treat. But unfortunately, because of the problem of antimicrobial resistance, those narrow spectrums are becoming less and less effective. So infections that were easier to treat. So a young man who is coming in from the community, meaning coming from home, with something that looks like a pneumonia, it should be an easy peasy treatment with, well, augmentin or rocephin, right? That's what you expect. You expect streptococcus and you treat him. Even if you're going to even treat for something resistant, you say, okay, we'll give him vancomycin or something because of staph. But Acinetobacter will not be even on your list of potential bacteria that will be causing this infection. So that's what we're talking about. So infections become harder to treat because these infections, these bacteria are gaining grounds where it's a continuous race. We keep trying to play catch up with them. So then it says leading to longer illnesses. So it's unfortunate that the young man we talked about died. But if he had stayed on, if he had continued to be in the hospital, so what happens is this: when he comes in, we get cultures, and those cultures take days to grow. So in as well, the thing that grew out was resistant. Guess what? He probably was already dead before they even got that culture, unfortunately. And we'll address that too, because it's part of the diagnostic challenges that we're having as clinicians. So at the time the culture results were coming out, because he had an unusual bug, he wasn't responding to treatment. If he hadn't died, he would have been in the hospital much longer. And then they will figure out, oh, this is what he is growing. So they will go back to the drawing board and reorganize their weaponry and try to fight the infection. And he may be in the hospital for longer. He may end up with all other complications just because in the hospital, because he has a tube down his throat. He may end up with complications from that. Maybe he has a urinary catheter. So in the long run, he ends up with higher medical costs and then greater risk of severe diseases. He may end up with disability because he was put in coma for an extended period of time. And then when it's time to leave the hospital, guess what? He needs to go to rehab to try to teach him how to walk again. So, and ultimately, it can lead to death, just like the example that we gave with this particular young man. Excuse me. Oh, I'm sorry about that. My family is just waking up. Where is my screen? There you go. So AMR is a top global threat. And I see I have some notes here. So it says infection caused by resistant bacteria among the leading cause of death for people of all ages. So in 2019 alone, okay, it's actually on the screen. So it's one of the most significant global health and development challenges. In 2019 alone, approximately 1.27 million deaths caused directly by antimicrobial resistance. And the patient we just mentioned is a classical example. He was one of that statistics. And it's also contributed directly or indirectly to 4.95 million deaths worldwide. Sorry. This happened. It's microbial resistance have been shown to be directly related to human activity. So we are the cause of the antimicrobial resistance, but because indirectly, not necessarily directly, because antimicrobial resistance is actually happening by the bacteria. So they are mutating, they are evolving. Like I said earlier, when you are in a fight with an enemy, but you come in with a weapon to try to kill the enemy, but the weapon maybe it the enemy, but does not knock him out, right? You give him time, right, to go back and reassemble. Guess what? He will come back stronger. So that's basically what happens in the mutation, or it's a genetic thing within the bacteria. But why did I say humans are the ones that it's related to human activity? Because we are the ones who are coming ill-prepared with ineffective antibiotics, or we're we're overusing the antibiotics when it does not have an infection. We just throw antibiotics at them. If you have a headache, I know sometimes in Nigeria, if you have every fever is treated with antibiotics. You have a cut in your hand, it's not infection yet, you get antibiotics. So misuse and overuse of antimicrobials in humans. And then recently, not people who have animal farms, they're giving the antibiotics to animals indiscriminately because they don't want the animals to be sick, either prophylactically and also even in plants. So all of this is fueling the drug-resistant pathogens, and then is leading on inadvertently to poverty, and then driving disease, patient outcomes. People are dying from all of this, and in the long run, the people suffer the most are the low and middle income. I wrote something here. I said this exceeds those for HIV, malaria, and drug-susceptible tuberculosis, HIV negative individuals, all put together. So that is significant. So I know the CDC reported that about 30% of all antibiotics prescribed in the US are either unnecessary or suboptimal. And that is talking about the misuse and overuse of antimicrobials. So we prescribe antibiotics unnecessarily, and both for humans and for individuals. Let's see. So what are the real-life impacts of AMR? So AMR puts modern medicine at risk. So it makes infections harder to treat and complicates surgeries, cesarean sections, and cancer chemotherapy. And this is significant because when I thought about this, I'm like, why do they put modern medicine at risk? Think of this, people are living longer, okay, because of, for instance, you see an elderly person who in the past would have died from a heart attack, but we're able to resuscitate, bring him back, and they put a pacemaker, kind of artificial heart, and then basically that pacemaker would buy him an additional 40 years. But when infections come into play, we end up with pacemaker infections, right? And it basically just jeopardized that advancement in medicine. So infections, especially infections, it is simpler they are to treat, the better. But when they become resistant, because I remember I had a patient who had a pacemaker infection that eventually ended up into an endocarditis. What that means is the infection started in his pacemaker, because those pacemakers like a box they put on the chest wall, but it has leads like wires connecting to the heart, right? That keeps the heart beating. And then what happens is when infection in the pacemaker tracked down the lead and it became an infection in the heart, and it was impossible to treat, he ended up with MRSA. MRSA is methicillin-resistant Staph aureus, and he succumbed to the infection after several recurring. They took out the lead, but it was already overwhelming. So that was threat to modern medicine. So people go in and successfully do a cesarean section, the babies are born, and then guess what? There's an infection at the site. So modern medicine that's supposed to be enhancing life is being jeopardized because of antimicrobial resistance. And then we talk about cancer chemotherapy. Patients who are second lease at life because of maybe they had a bad diagnosis with cancer, you give them chemotherapy and you're like, okay, good, we are beating this cancer, right? And you're happy. But then the next thing, you end up, and then you're trying to scramble for drugs to treat infection, and they are so at risk of multi-resistant infections. Several cases of resistant infections like MRSA, I just gave an example, ESBL, extended spectrum beta-lactamase, gram-negative rod infections, right? So these gram-negative rods like E. coli, Klebsiella, typically you give a penicillin or rocephin, but the more extended spectrum, so they have resistance to your drugs, the more powerful they are. And recently I've been seeing cases with carbapenemase resistant gram-negative rods, just like the example we gave with the guy with Acinetobacter. Okay, and over the last 2-3 years, we've been having Candida auris. So this is a fungus, okay, Candida. I don't know if you're familiar with Candida. It's Candida albicans, Candida. They are the more common variants that we normally just give a fluconazole and you're good to go. But Candida auris is resistant to all the antifungal therapy. And so we have to throw the kitchen sink at the patient. And then what we mean by kitchen is just throw all kinds of antibiotics and see antifungal and see what works. And what? We are having more increasing cases of Candida auris in the US and the world. So this has a global problem. Nobody is safe. Both high-income countries, low-income countries. It's just that the burden is heavier on the lower income country because resources that could have been diverted to economy will now be using it to try to of the antimicrobial. So it's up to an annual health cost. So these are estimates, right? But by 2050, up to $1 trillion in annual health cost is what is being estimated, and the global GDP loss could reach 3.4 trillion by 2030. And 2030 is just 5 years from now. So you can imagine these are really numbers. And world facing an antibiotic pipeline and access crisis. What do we mean by this? Fewer and fewer antibiotics are being so it's like what Americans would call a double whammy. So on one hand, the bacteria are becoming stronger and resistant to what we have. On the other hand, new antibiotics are not being made to fight or to even try to take up the challenge against potential. So we are always playing catch up with the early development of new antibiotics despite rising resistant levels. And so there's urgent need for, and there's access to vaccines, okay? Because if the vaccination, we prevent infection from even happening, right? That is right word, a legitimate and a very valid way of preventing antimicrobial resistance, because people may be like, what has vaccines got to do with it? But vaccines have very to do with it because it stops in the path, because if the infections are prevented with, then it would not happen. You need to be treated, and there will be less likely development of antimicrobial resistance. And then diagnostics. So I'll go back to Chidima. Chidima, thank you so much, because you are a very part of discussion. So she met the patient. The case study, the patient did not get the appropriate antibiotics to start with, and unfortunately, that's what we find. It happens to even the best doctors, because we have limited diagnostic, or not, well, they are limited, one, and then even the ones we have, there are limitations in what they can do. Don't know if that makes sense. So we don't have that many options, and then the ones we have are limited. So for instance, that patient comes in and you send cultures. A typical culture, you have to inoculate, you get the sample, right? I don't know if you're familiar, if we have any microbiologists in the house, yay. You get this, you clean it, purify it, or sometimes you inoculate directly onto the fish, and guess what? You cover it and put it in a place and you wait. You cannot hurry the bacteria to grow. They're going to take their time and they will grow. And when they do grow, they will now go in and take the sample and test for them and see what it is about, right? So all of those take time. But patients that are sick, they don't realize that this time is going and you're still doing everything you're doing on one end in the clinical aspect, while the microbiology are doing their job. So what we need diagnostics like the gene we had alluded to earlier that can give us rapid fire response. We don't have to wait for 5 days of culture or 2 weeks. And then, but there are some some microbes that are not culturable, right? So it's like we have a disease that we literally call culture negative infective endocarditis. What that means is, we know this patient has an infection. We can see it. It smells all over him, but culture is not growing. We know the culture is not going to grow. So what do? We have to take off our hats and try to figure out what antibiotics to use. So we need urgent need for equitable access to vaccines, diagnostics, medicines. So let's see what else. Okay, so this is a good segue into talking about the One Health approach. Let me just give a 2 minutes stop here, 1 minute. If anybody has any questions or comments before I run along. Any questions?
Christina is raising, I think she has a question.
Okay, go ahead. What did you say?
Christiana, are you there? Okay, maybe we lost that too.
I didn't questions in the chat because I can't even see this anymore. So.
I raised my hand.
Okay, go ahead.
Yeah, sorry, I was by network, so I just joined back.
Okay.
Yeah, thank you very much for class. I think there's one aspect we're not really emphasizing on more, even though economic burden of AMR should be priority, but we are not talking about the emotional burden. For example, now I have been down for a few weeks now, and I've gotten anti-malaria, but I will be okay, and before I know again, I those symptoms again. I don't know if I should keep taking it, but I can't keep doing that. So sometimes I just ignore it, but sometimes it weigh me down. But the impact of this on my emotions, I can't even describe it. So I feel like we should talk more about the emotional aspect of the burden it places on people. Number one.
Absolutely.
Number two, tax. We are in the era of artificial intelligence, robotics, and all those tools, technological tools. How can this deal with this antimicrobials? Because I think I've been doing my research on this. I'm actually someone that is interested in tech. I love tech because it just simplifies life, it improves your health. I mean, I'm interested in how tech in public health and all kind of innovations. It get me intrigued and excited. So I want to ask, I don't know if you can talk on how we can leverage tech to improve maybe the drug development and maybe areas like that. So that's just my question. Thank you.
Thank you so much. I was trying to find, I can't find the names of the person. What did you say the name is?
Christiana.
Christiana. Okay, thank you so much, Christiana. That was a really, really good contribution. I appreciate it. And I'm happy you brought that up because definitely the emotional burden and even talking about the economic burden broadly, but the burden to families is emotional burden to the people we seek, and then emotional burden to the caregivers because you
I'm
even if
sorry, even to the reproductive system of woman, because now I'm a married woman, but I can't perform my function because I'm sick and I'm treated it. I cannot. So that's one of the things I want to mention.
yes. So emotional burden. So all of those, they're all legitimate burdens. And you're absolutely right about tech. Hopefully, I don't know if we'll have time to to get to all of the slides that I have, but we should address, we should help. I kind of alluded to that when about genomics because the genomics, metagenomics, which is something I'm passionate about as a diagnostic tool, when it's powered by AI, can actually help also in mitigating this. So let's go right. Thank you so much, Christiana, for that. And you are right. Emotional burden, the psychological burden, okay, all of that to the individuals, not just to the global economy, national economy, to the individuals, emotional burden to the family, the caregivers, right? All of. So let's see in slideshow. Let's go on to. So what is One Health? So the One Health approach. I really like this. It's an initiative from the WHO. So I'm just going to run along right through this. So it was launched in 2018, and it's so I talked about, if you noticed, I was talking about antimicrobial resistance really through the lens of me as a clinician, okay, as a doctor. Most of us focus on as on humans, but it is the burden of antimicrobial resistance would not be tackled alone, just focusing on just humans, because all along the food chain, every effect, every time you give antibiotics, that path, it affects everybody. So for instance, the way antibiotics are disposed of, right? Maybe they are thrown trash enters into the water system. It goes through the wastewater management, and you drink some of the antibiotics. You are indirectly creating the cycle of antibiotic resistance. When animals have given antibiotics indiscriminately, it gets into their tissue. So you're eating chicken, but you think you're just eating chicken and sweet chicken meat, but you are eating tetracycline with the chicken, so you're exposing yourself to antibiotics. And then sometimes in plant plant care, they give some of these what do you call it, plant treatments. They are not the kind of antibiotics that you're familiar with, but they all have. So all of these things along the path of the food chain, if we don't address all of them, we all end up in the same problem. So if we focus just on humans alone, so this One Health approach is so remarkable. And they decided to one they use E. coli, ESBL, coli, kind of, I think I see that's like a starter trigger, something that they can focus on, and then from there expand into other things. So it says on a tricycle project. And what the tricycle means is, from you can see from this put here, it's kind of like, so we have the animals like poultry, and then we have the environment. So it identifies ESBL E. coli in human samples, e.g. clinical settings, blood cultures. So they are having a continuous surveillance of all of this. poultry populations, environmental samples like sewage, market runoff, rivers, right? And how do they dispose of their expired drugs? So you may say the drug is expired and they just throw it into the ocean, they throw it into the river, all of the waters in the world, they all circle all around. So it's connecting health data sectors, right? So it's so powerful because there we see a collaboration between people who dealing with both the humans in terms of the clinical aspect, those who are treating disease, those who are in vaccine production, those who are in the public health sector, with animals. So we have a veterinarian here. Thank you for joining the program. Those who are treating animals, those who are caring for animals, those who are farming animals, right? And then we have those who are in the environmental. So it's a wonderful collaboration of cross sectors to try to tackle the antimicrobial problem. So it was first piloted in 9 of the member states in Ghana, Indonesia, Madagascar, Malaysia, Pakistan, Senegal, India, Jordan, and Nepal. But now 5 new countries. I was excited to see Nigeria in one of the I heard someone introducing from Kenya. Yeah, so happy to have you here. So you may want to go back and get your country involved. So we have the sharing data. So GLASS model. I think the GLASS stands for global. Let me see. I wrote it down because it's something surveillance. I think global surveillance system. Yes, that's what it is. Global antibiotic surveillance system model for countries. So they're able to share surveillance data and antimicrobial resistance. And it's so important because data is what powers everything. If you don't have the right data, you just be running, okay, but you're running without direction, because data helps you into your choices, and it also gives you a clear understanding of the magnitude of the problem or the enemy or where to start from, which is more critical. So data is very important, and then it strengthens collaboration across human, like I said, food chain and also the environmental sectors. So run through this, support development of national surveillance system, and then it's a holistic fight, it's data driven, and then we have it's not just all talk, right? So this is just a picture illustrating everybody coming together, work to overcome this of microbial resistance. What are the innovations? So back to what Christiana had alluded to. Thank you so much for that contribution again, Christiana. So we talked about, we're going to, right? So quicker, smarter tools for antibiotic stewardship, right? Because the quicker we can get okay, so let me give you an example. For instance, when a patient, you're like, well, I don't know, maybe at the primary care doctor's office, right? So you're having a fever and they're like, well, maybe it's malaria, maybe it's flu, maybe it's this, maybe it's that. A lot of maybes. So what happens is, the typical thing is to just, well, write a prescription for augmentin and maybe send cultures or send something out. And that may come back in about 2 or 3 days. By that time, the patient is taking it. The antibiotics may or may not have done anything, but the patient feels better. But if we do have rapid diagnostic tools, we can get, before the patient leaves the doctor's office, then we can precisely tell the patient, oh, so this is your result. You don't need antibiotics because, see, confirm this is what you have. If I give you antibiotics, it will hurt you because antibiotics is poison, right? It's poison if it's not doing what it's supposed to be doing. Everything has a side effects. Apart from the general side effects we are talking about of antimicrobial resistance, it can hurt you. So rapid diagnostic tools, smarter tools for antibiotic and antimicrobial stewardship. So AI surveillance, so data to track. So for instance, the young man who was in our case report, who was a 19-year-old, if for instance they had in that they were having cases of Acinetobacter resistant bug in the community, that may have triggered the doctors to know, well, instead of just bringing out the narrower spectrum drugs, right, they would know to bring out something a much spectrum right off the back at the very beginning of him presenting. So track resistant patterns, and when there's information, then when you have then you can walk backwards and see what happened here, right? What happened in the you can almost try reading in one of the articles while I was researching on this about I can't remember which country, how they're able to find a particular strain of a bacteria that was present in the chicken poultry farms, and they realized that it had the same protein within the DNA of the bacteria was what they were finding in clinical samples. So they could just kind of trace the line back. That's what data does. So we're not just so data helps us. And so once we can trace it, okay, this is the problem, this is how it entered into the system, and now we can try to figure out what to do about it. And then alternative therapies, so cutting edge solutions like phage. So this is really exciting. I'm not sure if you're familiar with what phages are. Phage is a virus that infects so bacteria infect humans or animal cells. But they have their own too. So phages are bacteria that exclusively infect bacteria or something. There's still some area of medicine that there's a lot of on how we can tap into this as a form of treatment. So instead of giving a typical antibiotic pill, you can give a phage. If we E. coli, ESBL E. coli, extended spectrum beta-lactamase E. coli, for instance, is infecting the patient, instead of giving the patient carbapenem or meropenem or whatever, of course, you can't give recephin for ESBL. What you do, you get the phage that would attack that E. coli, and you give it to the patient, and guess what? It will kill that E. coli, right? And phages are very, very specific in their killing abilities. So if you have the right phage for the right bug, you can be rest assured that the bug is done. That sounds like a tweet. So I'm sorry, I'm just when I'm talking about infections and infectious diseases, so please excuse my excitement. So phages are being an option. And I was looking into this recently, just studying about phages, and you have the lytic phages. So there are two types of phages. You always want to get the right one, because there are some other phages that actually can enhance antimicrobial resistance. Because if the phage is not, if you don't use the right phage and you use a phage that is kind of like a static, it's not, they call them lysogenic phages, don't kill the bug, they just go in and hang out with the bug, they can actually enhance transmission of resistant genes from one bacteria to the next. So those are challenges that we can observe with phage therapy. So everything has challenges, but the more data we work on, the more technology improves. There's a lot of exciting things in the horizon. Also, microbiome treatment. So, hello? Okay. So microbiome treatment. So the microbiome is an exciting part of medicine, precision medicine. Is the component of microorganisms that are on you. So like the gut, it's my understanding, the gut is basically the largest community of organisms. Somebody's trying to say something. Okay. So both the bacteria, the viruses, so you have bacterium, the virum, or the fungal population. When you have an understanding of the patient's microbiome, you might be able to come up with to take care of certain diseases. So all of the alternative therapies are just ways of mitigating use of traditional as options. And we're talking about using technology, and that's why next generation sequencing. So sequencing all kinds of precision medicine options would mitigate antimicrobial resistance by bypassing using typical antibiotics or antimicrobes. I already touched on that earlier because it's kind of early. If you have vaccine, you prevent infection, then you reduce the likelihood of having infection, and then you reduce likelihood of using the antibiotics, and then you in the long run you mitigate the resistance. Even you can be conscious an individual, you requesting for, and also start advocacy with your own within your own influencer, within your own family, or within your own community. You can go into politics, okay, even as a community, and try to initiate policies, whether antibiotic use at the human level or at the poultry or farming levels or the environmental levels.
I have a question.
Please go ahead.
You had noted that AMR poses a risk in cancer, chemotherapy, and performing surgeries. So I have a question. How can healthcare systems prepare themselves to counter the that are caused by AMR when they perform these procedures on patients?
That's a very good question, Juma. Thank you so much. So one way that healthcare can mitigate that is what we call antimicrobial antibiotic stewardship. Okay, so a very specific guidelines to the Infectious Disease Society of America, for instance, which is under the body under which I practice. They have very, very specific guidelines, and each hospital systems have antibiotic or antimicrobial stewardship curtail this, okay? And so that the right antibiotics is prophylaxis, and then after the procedure, and also very, very importantly, is having what we call an antibiogram. So where you have a clear understanding of the common bugs or the common bacteria that you encounter in that hospital. So for the hospital, an antibiogram, and also for the community at large. So that way, we are trying to get us ahead of the bacteria. So that way, it will becoming a hindrance in a patient who should have benefit from modern medicine. I don't know if that. I hope that answers your question.
Yes, it does. Thank you.
You're welcome.
Okay, so is there any other before we round up?
I see a question. I say using phage therapy, can it treat all bacterial diseases? So potentially it can, if we're to know if we can have the phage for this bacteria, because it's very precise. It has to, because if you put a bacteria in the midst of a phage that is not effective, it's not going to do anything. Because the phages, the specific phage recognizes a receptor on the specific bacteria, and then it sends its chemicals into the bacteria, and then it multiplies, and then it bursts the bacteria open. So that's how it works. And so, and then it just from one bacteria to the other, and then it can. So potentially yes, but we don't know yet because we're still learning about it.
Okay, I think someone just asked a question now on the chat box.
Okay.
I would like to ask someone like me that has treated malaria with antibiotics and still, okay, what is it? And still symptoms. How do we address?
Yes, unfortunately, that's part of the burden of antimicrobial resistance. So one thing I would say from an infection disease, point, which is my specialty, is number one, do you really have malaria? So they need to confirm that you have malaria. So if yes, you do have malaria, it's possible that the malaria you have may be resistant. May be resistant. So I remember when I went to school, I went to Nigeria, I went to University of Lagos. Yay, Luth. There was we used to treat malaria with chloroquine, right? But now you can't even bring chloroquine out to treat any malaria and probably most of the very few countries that still have chloroquine sensitive malaria. So like I said, the bacteria, the parasites, the fungal, they just seem to be getting one step ahead of us, and new medications are not being produced. Like for the longest time, now you have the artemether-based drugs that you use now that are mostly effective. And that's good because there was a time when it was almost like malaria was almost becoming a death. It used to be ages until we started having these new drugs that are effective. So they may need to test you for resistance to check if you're resistant to the therapy that you're getting, or on the other hand, which is also part of the problem we have in developing countries, the drug be a fake drug. So you have to be sure you're getting the drug that is not fake. I'm trying to find the correct way to put it, but nothing is coming to mind now. So make sure you're getting to treat it. Also checking for resistance. Also confirming that you really do have malaria, and it's not do have viral illnesses in Nigeria that are non-malaria that will give you symptoms that look, smell, and behave like malaria. So that's what I would okay. But I'm sorry that you're through this. So you're having a specific study to what you might be a specific study to what we're talking about today.